And good morning, everybody. It is the Weekend Journal on News Talk 580 WTCM, brought to you by Rectangles Rugs in Traverse City. I'm Jack O'Malley, and I've talked about this show now for a couple of weeks because I think it's going to be a very interesting one because I've got a couple of knowledgeable guys on in the studio and on the phone. And today's topic is mental health. I have, like every citizen, and then as a legislator, it's like, why? What? How come? It shouldn't. To me, it doesn't seem like it should be a big problem. But you have a lot of people, a lot of cooks in the kitchen, so to speak. So I thought I would bring in a couple of guys I know that know a lot. On the phone is Steve Barnum. Steve is a lawyer, and I don't hold that against him. Who lives in the Kalamazoo area. He's an attorney who has worked for private, nonprofit, governmental agencies, all with the idea of mental health. And in studio with me is Chip Johnston. Chip, I've known for a long time. He probably doesn't want me to say this, but I will say it. He is known far and wide as a guy who's probably been in this business a really long time, and he knows a lot of stuff about it. And he runs the community mental health in Benzie and Manistee. Gentlemen, thanks for being with us today.
Yeah, thank you. Appreciate the invite.
Thanks for having us.
You bet. All right, so to start, and I mentioned this to Chip and to Steve, here's how I see the history, because there's a lot of people who are listening that maybe forgot or weren't even born. But I'm going to go back 40, 45 years. I think Governor Engler was in office. And the idea was we're spending a ton of money on mental health. We've got these old, dilapidated state hospitals. They're costing us a fortune. Plus, we're moving them away from state hospitals because they're icky. It's all one flew over the cuckoo's nest stuff in there, and we don't want anything to do with it. And we can save money by using medication. And so they closed them down. And that was probably one of the biggest boo-boos because there are a certain number of people that just need care. And we find ourselves now in a state that has a lot of mental health problems. Again, I don't understand it all. But we also don't have enough beds, and we seem to not want to have beds. So with that, I would ask Steve and Chip, am I right? Am I wrong? Is that a good place to start this conversation?
Yeah, I'll just say as a guy who was chasing clients around the streets and in the backwoods back in the day, back in '89, early 1990s, we had probably 2,000 beds or so. In 2006, we had 1,200 beds. And so it wasn't quite a problem. Even with the closure of Traverse City, I was still able to make referrals. We still had places to go. So, Steve, I don't know if you want to add any more context to that, but from a guy who was shiny and new out of college, I had choices and options.
No, I would agree with you, and I think, just to add a little bit more detail, or if you will, layers to what Jack's already laid out, in the 60s, we probably had 20,000 people in state hospitals, and that wasn't necessarily good, but they shifted from custodial care. We had developments of treatment, changing societal views as far as what mental health is and what can we do with it. And Jack, you mentioned, that they went too far. I think some of the folks, and I've talked to some of the folks because I've been involved since the 90s, that were instrumental in closing down those. They had a plan for what it would do, and they never meant to pull out the entire safety net. And I think they've just taken it too far with taking away all the beds. You can't serve everybody in the community, nor should you serve everybody in an institution. There's got to be a balance. And we have to right that balance because we don't have it right now.
Right. And I think what's important to note is, President Kennedy and the mental health laws that came out of the federal government came down to Michigan with the Michigan Constitution. There's a lot of effort in putting services in counties to have boots on the ground close to the client's home, to provide some protections for them and resources prior to having to utilize state facilities. So it was kind of a more humane approach, try to work on things locally before you had to use some of these archaic places.
Yeah, but on the other hand, sometimes people just when we closed down those mental hospitals, sure, maybe because they were 100 years old, they were expensive to keep up. But somewhere along the line, let's build something new and modern. And we're not putting people into a mental institution because they're having a rough period or they've got the vapors like maybe they did, and no electric shock therapy or whatever was happening in 1900. To Steve's point, a mix is what you need. You always need a mix. Just to have a good flow of things. So, all right, now let's move forward a little bit here. Again, as a civilian, we've got issues. There's somebody is ill, they can't get a bed, or they're just. Why are we where we're at today? Because am I wrong? But it just seems like we're spending a lot of money on mental health, but we're not getting much. I don't want to overstate it because sometimes we can get a little too rough in that, because good things are happening, and we'll talk about that. But overall, we've still got problems. I mean, our jails. Why do we have mental patients? I once took, and I know I'm rambling, so I'll shut up, boys. But I once took a tour of a jail, county jail, and I said, why is everybody in? I assumed they were going to say robbery, burglary, that sort of thing. Alcohol and drug abuse and mental health issues. And I'm like, what?
Yeah. So, Steve, do you want to start with the systemic, and I'll talk about how it's impacting the local community?
Well, I think part of it is it's almost like the department has a theory of, and I just read this recently, treated and streeted. We treat people in the ED room, kick them out. But then the problem that has, and I'm good friends with my sheriff down here. I've known him for years. We have coffee frequently, and exactly what you were just saying, Jack. The jails have become the mental institutions that we used to have in the 90s. If we don't treat them otherwise and be proactive in getting them early treatment, which may include an inpatient, they're going to end up in the jails, and they're going to end up with a criminal charge. And all these are very avoidable if we had more available beds. So the whole continuum of care that the CHIPs of the world, the directors of these local community mental health boards, if they had better access, they could better manage how they serve the folks in their community.
And I think one of the other major shifts that occurred during the Engler administration and some of the reasoning behind closing those was not only altruistic, but when someone's in the community, you're allowed to use federal funding versus if they're in the state hospital, it's state dollars. So how it plays out on the ground is when somebody is beyond our ability as a local community mental health to handle, and usually there's a violent tendency or they're reacting to something that we simply can't handle, and folks are being hurt or there's threats. Back in the day, we could say, listen, this is just beyond us. And there was a collaborative arrangement with the department, and boom, they would be in 30 days, stabilize, back. It was a nice partnership. Today, and I've talked to directors from the Western UP all the way down to the state line. Their frustrations with, we as a community mental health have identified somebody with our community partners, the sheriffs, et cetera, who needs to go in now. And it turns into a Mother May I begging, having to go to extremes to try to get them to take somebody, all the way to having to do judicial admissions, where you didn't have to necessarily do that before.
So why is that? Is it because DHHS is checking boxes? I've got a couple of stories that I won't share, but where I know departments are basically going on percentages. You can have this percentage of admissions or whatever it was. And if you go over that, we're coming to find out why. Is that part of it?
It's part, yes. They want, a lot of it is they're checking boxes to see if the locals have certain programs. Did you run it through your sort of community treatment team, all of that stuff. And if you don't have a box, well, they point the finger at you. And particularly in rural communities, we don't have the professional staffing to staff these more urban models. And so we're stuck with trying to figure it out on the ground. And so, what's really hard is when you have, particularly a child, where when I started, we had 500 beds statewide for kids, and we're now down to 23.
23 beds for kids. And I'm assuming that's 18 and under?
Yes.
Okay.
Yep. And they are looking to expand, but they're looking to expand to 72. So, what happens invariably is someone will go into the home or into the hospital, and the hospital now has to deal with them. They have to provide security, etc. And the family's like, we're not ready to take them back. So it puts the family in a bind, it puts the hospital in a bind, it puts the CMH in a bind, and the sheriff in a bind if they have to staff that local rural hospital, for example.
Sure.
And so we sometimes, I've heard of waits in the hospitals for up to 3 weeks while the department tries to
Figure a spot out. Well, Steve, let me ask you, because I know you deal with groups all across the state, and I don't want to be a us versus them kind of thing, but I know it's there. It makes it even tougher when it comes to anything, but specifically mental health, when you're talking about rural versus urban. Would you agree with that?
Oh, absolutely. I think Chip nailed it. And I do. I have some boards that I work. I literally, like Chip said, I'm in the western side of the UP all the way down to the Ohio, Indiana, Michigan line. I have different boards, and they have different issues. And to one of the points Chip made, a couple of years ago, I had a situation where I was dealing with 3 different clients, one northeast Michigan, one northwest Michigan, and one lower Michigan. And it dawned on me that my 3 clients were all fighting for the same one bed.
Wow.
And that's just to my clients. So I can't even imagine statewide what was going on. I look at a lot of this as, and I hope this is answering your question. I look at a lot of this, I call it, the state's given us a box, 500-piece puzzle, and we're supposed to do this whole continuum of care. But Chip and the directors in the system know going in, there's 10 pieces missing. So they'll never be able to finish this because the 10 pieces are those inpatient beds that allow them the flexibility. Like Chip said, if they notice that somebody's starting to, drift or, need some more issues, we don't have anywhere to turn but trying to serve them in the community. And you can't serve everybody in the community all the time. We're not looking to bring back 20,000 beds, but we need to have that ability to serve to the best we need. So in the 90s, when the state kind of said, you know what, we're going to turn this over to the locals, and we're going to take a more hands-off approach. The thing that didn't change, though, the Michigan Constitution and statutes still say it's the state of Michigan's responsibility to provide this and make all available resources. It's right in the code and in the Constitution. They give it all to the locals. I totally buy into that theory. I think Chip knows what's best for Manistee, Benzie, and the citizens up there than somebody down in Lansing. Like somebody in Lenawee knows what's better for Lenawee than Lansing. But that does not allow the state to just totally wash their hands and walk away from it. And I feel like they have, both in the rural areas and in the urban areas.
Yeah, and to build on that, when they started closing the hospitals, Steve, part of what they wanted to do is to move a lot of that treatment to private entities, such as Munson up here has D6, etc. Well, what happened is, they shut down the state hospitals. And our go-to next was the privates. The privates don't want to take some of the folks that would be intended for the state and have over time shut down. I mean, we used to have a hospital in Ludington. We now again have one in Petoskey, but we used to have many, many choices throughout the region. And they have shut down to the point where Michigan, per 100,000 people, is about 1,000 private beds short. And so the mix between needing the privates for folks who can be stabilized in the community and sent home rather quickly within a week or so, versus those who need like 30 days, maybe 6 months in the state facility.
And so that's one of the keys. We're not talking about somebody who's going to need to be taken care of for life. We're talking about somebody who needs to be stabilized a couple of weeks, a month, then they're back home.
Right.
Correct.
Yep.
And I would also argue, in Chip's clinical, I'm not, but sometimes I've had discussions with some of my directors, and we finally get somebody in, and they're like, well, they're almost afraid to bring them out to try in the community because it's so hard to get back in. If I pull somebody out in 30 days, they decompensate in 10. I know I'm back on the back of the line to get back in. So, it's almost a self-fulfilling prophecy by having it that tight.
Mm-hmm. So, all right, we got a little bit of time here. I got a couple of stories that I saved that I saw. And by the way, folks, we're chatting with Steve Burnham from Kalamazoo, who is an attorney who works with many community mental health organizations, and Chip Johnston from Benzie, Manistee. One story, I wish I knew what it was from, it doesn't matter. Michigan is the lowest 10% across the country in terms of state psychiatric hospital beds, according to the Deputy Director of State Hospital Administrators. According to the Department of Health and Human Services, state psychiatric hospitals oversaw 669 admissions last year. Somehow that seems like it's kind of a low number. Right. And then the other story is a federal judge gave preliminary approval Thursday to a settlement in a 2018 lawsuit that accused the state of staggering failures in providing behavioral, emotional, and psychiatric services to Medicaid beneficiaries under age 21. So I guess my question is, and I don't mean to pick on anybody, but Department of Health and Human Services is the big dog on this. They're the big casino. How are they doing? I would, from what my take on it when I was in the legislature, there's a lot of people who mean well, but it's become just this monolithic, who knows what's going on behind those doors. Am I wrong, or do you guys want to be a little more diplomatic?
Oh, boy.
Oh, boy, that's right. Well, I will say that there's legions of people who don't know the history. There's legions of people who don't understand the interplay or their ultimate responsibility. And so I liken it to, they've just graduated from pick your college, and it was a nice dissertation, and they think that they can come out in the field without understanding the core of our system. And it's creating over and over policies that'll come out, and then veterans or people in the field saying it doesn't work that way, and then they're having to reverse themselves frequently. Mm-hmm. And the same can be said for any inpatient fights that we have. In fact, they had to close a facility. This is a bit of a segue, but they closed the one in Shawano, which is over in Roscommon. And the reason they closed it because there wasn't enough staff. Yet they'll yell at a CMH in the rural communities who doesn't have enough staff and needs an admission to staff that home and to sit on somebody and to help them, which we really want to do if we can, but if it's not safe, they just are having a hard time understanding how it is out here.
Gotcha.
So that's from my perspective, Steve. Go.
So I'm going to build on that if I could, and not to do a deep dive or go too deep into the weeds, but in the 90s, the mixture between the general funds that the state provided and the federal funds was more like 65 local state funds, 35 federal funds. As we suffered budget crunches in Michigan, they started falling in love, as a lot of states did, with the Medicaid money. And the way that kind of worked was the state gives $1 to the feds, and the feds give you back $2.25. In theory, that sounds good. But the trade-off to that, if you will, is the more into the Medicaid you get, and picture your own Blue Cross for your own health care, it's a lot more categorical on what you can do and how you can serve people. And like Chip said a little while ago, Medicaid dollars can't be used for state inpatient. That's another reason. I'm not saying they did it purely for the money, but they drifted away from doing that. So now it's more like, and Chip can correct me if I'm wrong, it's more like 95% Medicaid, 5% general fund. So the impact of that is, if Chip sees something that he could help somebody with, but it doesn't fit your insurance code, he can't do it unless he wants to tap into that 5%. So there's a lot more money in the system, and people are always going to hear that, and the department will say that. And that is true, but it's a little bit harder for us to always spend it, because it's just like you want a particular treatment. If it doesn't fit code that you're covered, you can't have it done unless you want to pay out of pocket for it.
Mm-hmm. Yeah, my greatest nightmare is a child on private insurance who needs a facility admission,
Yep.
Anyone on Medicaid, it's even easier, but that is my greatest nightmare.
Really? The
Yes.
private insurance.
Private
Yes.
insurance.
Wow.
Because we don't have the resources.
All right, gentlemen, we're kind of at time for this segment. I'm going to task you. We're going to take a break. And I told these guys when we started is I just don't want a whole show of piling on. These are two guys that have been around the block probably more than once. And I want, what are some positive things that we could do in this state to make our mental health situation better? And we're going to find out coming up in just a moment or two here on the Weekend Journal. We'll be back in just a moment. We are back with the Weekend Journal here on News Talk 580 WTCM, brought to us by Rectangles. I'm Jack O'Malley, and I really enjoyed the first segment today with Steve Barnum from the Kalamazoo area, an attorney specializing in mental health issues, and Chip Johnston, who is the longtime director of Benzie Manistee, a community mental health and all that goes with it. Gentlemen, thanks for being here. Are you ready for the lightning round, I guess we'll call it?
Bring it on.
Yes.
As I said before break, we could have made this just a complaint session, but that doesn't do anything, right? So you guys have been at it a while. If you could wave your wand, what would you do? 2, 3 things that we could do right away to just make things better. Steve, we'll start with you since you're the one on the phone.
Okay, well, that's great, and I like that approach because I try to. I'm sure there's people that would argue differently, but I always try to, when I'm presenting a problem, whether it be to a court, a client, the department, you always want to give some solutions. So one of the things that I would like to see, and I'll be honest, back in the 90s we had more of this, is more of a collaborative relationship with the department. You could pick up the phone and call somebody and talk to somebody there. And I think some of the issues, and I don't want to even call them barriers because I think the state people all mean well, but it gets frustrating when we can't hear or we can't communicate with somebody. So I'd like to see a more collaborative relationship with the department. I know the system would like that. And then towards the CMH system, the local boards, just being more out there and explaining to folks what we do and don't do. A lot of times I think, and I realize it's a radio show, but in the press, if something happens and they say they're mentally ill, they automatically blame the community mental health board on it. So we need to be better able to explain what we can and can't do. And we need to be involved in our community. That's why we have community mental health boards. So that would be 2 main things right off the bat.
Mm-hmm. Yeah, and to pick up on that, I think, in the communication with the department is, attentive listening on their part and active dialogue. I believe that they need to get out of Lansing and come visit some folks and places and have conversations with community mental health, the sheriffs, and look at solutions and to try to bring those back and to try to allow flexibility in our service approach, particularly on the Medicaid side. It's a lot of folks say, well, that's a federal thing. This is how it is. Well, there are options and opportunities to do demonstrations, to try things different, to do a lot of prevention programs to keep people from even getting to the point where they're in the hospital. I like to take a lot of pride in the fact that we've had a school program since the mid-'80s where we've had social workers in the school to identify kids early. So, just to foster policies that promote that and to fund them. I wouldn't even say we need more money right now, just to fund that flexibility. Mm-hmm. And I'm often, I will often say, I'd rather have $1 in local or state money than $10 in federal money. And if you were able to make that federal money acknowledge a rural intervention versus an urban one, what works for Detroit does not work for Manistee. But we're all trying to get to the same solution, right? And so that is to have a milieu of options up to and including the state hospital. Mm-hmm. To make sure that they're there for that. And to, as you said, Jack, to not just sit there and check boxes for an admission, to listen to what's really going on. And then, finally, like you said, Steve, we as CMHs need to do a much better job, particularly from the CEO executive level, explaining to our local sheriffs what our options are, what it means that this person's sitting in the jail, what we're trying to do, and have that constant feedback loop to solve for right now, to solve that situation in the jail and to try to support the jail to our utmost abilities. Because I always look at it from a CMH perspective, that is the number one job that we have. Our number one job is dealing with the crises, dealing with folks that are interfacing with EMTs and sheriffs and keeping the community safe. All else, to me, falls by the wayside and is nice to do, but that is our number one job, and to support that and to support the community. Sometimes I say, despite the state of Michigan and what their policies are now, to make our community feel safe and integrated. And it would be really nice if to have the state come and understand those issues.
So we've got a little bit of time here, and I don't mean to sound like I'm regressing here, but it sounds like, again, like a lot of things, DHHS needs to be less monolithic and understand that you can't just check boxes.
Right.
And the other thing in our discussions that sounds, from what I've heard from you guys, is the state and the discipline as a whole needs to, we have a problem with the middle of the road psychiatric patient. If they're really out there, they've got a better chance. But the average person is not standing on a ledge or, on the deep end. They're having issues that need to be addressed, and we don't do a real good job of that. Is that correct? Is that something else that if the state and the whole program could say, hey, Tommy Jones here just needs a little bit of help. He doesn't need massive amounts.
Right. Yeah. A lot of it is kind of we're not going to be out there till you actually break a leg or you're actually threatening suicide. Versus if you had take the senior centers, for example, they have Meals on Wheels. Folks go out. I have paid folks on Meals on Wheels to identify seniors who are lonely. Then I send a worker out. I hook them up. Sure. I try to get them involved and and to address them long before it gets to the point where now we're looking at a hospital bed or taking up a space for someone who is in active acute crisis. And to me, one of the things I would like to see in the state of Michigan that hasn't happened is with all these programs that the state of Michigan has done with the federal government and through the department, is to have more legislative oversight and understanding as to what goes into those so that it can reflect the needs of their community. I was listening to testimony the other day from someone over by the Thumb who said, like we talked about earlier, I have folks in jail. What are we doing to help them?
Yeah.
There are some interventions going on right now, but what more can we do? And it would inform the department, and the legislature could see that is what's being sent up and what we're paying for.
All right, gentlemen. I always say I have a quote that I can't remember who said it, and I can't remember it exactly, but it goes something like this: even though all our trials and troubles remain, thank God, so do we. And right. Knowing you guys are in the fight, you're not quitting, and that's a good thing. And there are a lot of good people in the community mental health space that are trying to help those who need it. So, Steve Burnham, thank you for joining us. Chip Johnston, is always good to see you. Thank you for being a good local guy, and we appreciate you being here.
Thank you very much. Thanks, Jack.
Thanks for having us. Thanks for covering this.
You're very, very much welcome. All right, the Weekend Journal. I'll be back with my headlines coming up. Stay tuned.